Good afternoon. So I'm Eric Weiner, and I want to welcome you to this pre-St. Gallen Satellite Symposium. The title, as you know, is Optimizing Outcomes in Early Stage Breast Cancer by Tailoring the Use of Chemotherapy. And I have to say that this fits quite well with the theme of St. Gallen this year, since we will be looking over the next several days at trying to provide each patient with the right therapy for her and occasionally him. And that means being much more tailored in one's approach. This morning, I'm going to start off with a brief introduction, and then my four colleagues to the right, Professor Ahmad Awada from Belgium, and Professor Antonio Lombard from Spain, Professor Joseph Gligorov from France, and Professor Ulrike Nietz from Germany will be each presenting a case, but will do more than that. They will also be giving you a great deal of background information about that case and how the decisions around chemotherapy were made for that specific person. And we're hoping with all of this, and this is a pretty aggressive agenda, that we're going to have time, at least 15 to 20 minutes at the end for questions. Without further ado, why don't we get going? So that's us. This is sort of a test question, sort of a real question. And if you could please vote. Do you have access to multi-gene assays? Yes. No, but I would like to. No, I do not have the need. If you answer 3, I sort of wonder why you're here. And I'm told this just happens. Is that true? No? Oh, there we go. Actually, 65% of you have access to these assays. 32 don't, but would like access, and a few of you don't, and you don't really think that this is necessary. So I'm going to start off with about a 10-minute introduction. And so this is really focused on the role of the 21-gene recurrence score in decision-making for ER-positive breast cancer. And here are my disclosures. So I want to go through the TAILORX study. I'm sure many of you were at ASCO and heard this presented. Those that did not hear it presented may have read it in the New England Journal, and I will keep this relatively brief, but TAILORX accrued just over 11,000 patients between 2006 and 2010, and on those patients, a recurrence score was performed. For patients who had a recurrence score that was less than 11, so 10 or below, these patients were assigned to hormonal therapy only. There were 1,629 of these patients. The hormonal therapy was left to the discretion of the physician and the patient, and they were followed. Patients who had a recurrence score of greater than 25 were instructed to receive hormonal therapy and chemotherapy, and there were just under 1,400. But the bulk of the patient population, in fact, had a recurrence score between 11 and 25, and these are the patients who were randomized to receive either hormonal therapy or hormonal therapy plus chemotherapy. Again, the decisions about the specific hormonal therapy and the specific chemotherapy were left to the individual treating doctor. Before getting to the randomized patients, I just want to point out the outcomes for the roughly 1,600 women who in fact had recurrence scores that were less than 11. These patients received hormonal therapy alone, and these are the 5-year results. The distant relapse-free survival was 99.3%. The invasive disease-free survival was 93.8%, overall survival 98%. So I think it's pretty clear, given a distant disease-free survival at 5 years that's in excess of 99%, that this is not a group of patients who would have been helped by the addition of chemotherapy. Remember that chemotherapy exerts almost all of its impact during the first 5 years after a woman's diagnosis. These are the results from the randomized patients, and this is the entire patient population, the intent to treat population, with recurrence scores of 11 to 25. And even if you squint, you cannot see any space between these curves. They are entirely overlapping. Distant recurrence-free interval of essentially 95%, overall survival of 94%, and no difference between patients who received endocrine therapy alone or endocrine therapy plus chemotherapy for the population as a whole. We'll get to some of the subsets in just a few minutes. And these are the 9-year event rates by recurrence score. So again, for those patients who were assigned to hormonal therapy alone, who I showed you just a few minutes ago on that slide, there was at 9 years a 3-year distant recurrence rate with endocrine therapy alone. For women who had recurrence scores of between 11 and 25, a 5% distant recurrence rate with a less than 1% difference for all endpoints. I do want to remind you all that these patients all had node-negative disease. And for patients who had a recurrence score of 26 to 100 and were assigned to receive chemotherapy, there was a 13% risk of distant recurrence through 9 years. Now, I think in many ways, TAILORX certainly adds a great deal of weight and is far more definitive than what we had seen with NSABP B20. Remember, B20 was a study that was conducted now almost 30 years ago that randomized patients to tamoxifen or tamoxifen plus chemotherapy. And in this prospective study, there was the retrospective analysis that was applied to it with the recurrence score. And for women who had recurrence scores of 0 to 10, there appeared to be essentially no benefit from chemotherapy. For those with scores of 11 to 25, essentially the same situation. In contrast, for women who had scores between 26 and 100, the absolute benefit, and now this is averaged across the entire group, was a 26% absolute benefit from the addition of chemotherapy, looking much more like the kind of benefit you would expect perhaps in the setting of triple-negative disease than typical ER-positive breast cancer. But I want to remind you and point out very clearly that although this is average, there's going to be a big difference between somebody who has a recurrence score of 27 and somebody who has a recurrence score of 80, because it is a continuous variable. Now, there's been a great deal talked about in terms of the subsets, and the subset that received the most attention were women under or equal to 50 versus those over 50. Very clearly, in this group of younger women with recurrence scores that were 0 to 15, there was an outstanding prognosis with endocrine therapy only, with a 3% distant recurrence rate, and I think we have no difficulty saying that for this group of patients, there's no value in the node-negative setting for adding chemotherapy. Among patients who had recurrence scores of 16 to 25, there was some chemotherapy benefit. Now remember, this is a subset analysis, an unplanned subset analysis. Among women who had scores between 16 and 20, there were 9% fewer invasive disease-free survival events, but only 2% fewer distant recurrences, 6% fewer events for women with scores of 21 to 25, which mainly consisted of distant recurrences. And what this has led to is some very in-depth conversations with patients about the results of the overall trial and the results in younger women. And I think it's fair to say that for women who have recurrence scores of between 21 and 25 and are 50 or less, we really cannot ignore the possibility that chemotherapy could have some benefit. The one added point, however, is that as we know, ovarian suppression in that group of women under 50 also has a benefit, and we know that from the SOFT trial, which came out after the TAILORX was started, and only 15% of the patients received ovarian suppression, and the vast majority were over 40 at study entry. So what are the take-home messages from TAILORX? For women over 50, there is clearly no benefit for chemotherapy with recurrence scores up to 25 in the setting of node-negative breast cancer. In truth, I think the role of chemotherapy in women who have scores from their tumor between 26 and 30 is uncertain at this time. For women under 50, there's virtually no benefit up to 20, with some clinically significant benefit between 21 and 25, but much or all of this may be due to ovarian suppression, and given the fact that this was a subset analysis, we definitely need to be cautious with these data. So I want to turn and talk now for just a few minutes about node-positive disease, because as you know, TAILORX only applied to node-negative disease. What do we do about patients with lymph node-positive breast cancer? And here we have 3 studies, in 2 cases registries, and another a prospective study that provide us some data. So this comes from Israel. And this was a registry that enrolled patients who had both node-negative disease, but here focused only on the node-positive patients. These are patients with either a microscopic metastatic disease in a node, or more commonly 1 to 3 positive nodes, and had recurrence scores of 0 to 17 and received endocrine therapy alone. And what you can see in that blue line is that the distant recurrence rate through 7 years is about 4%, somewhat higher for those with recurrence scores between 18 and 30, with a 5-year rate of just under 10%. The rate of breast cancer death is somewhat lower, just as you would expect. I will point out that in this experience, there were patients who had recurrence scores both between 0 and 17, as well as between 18 and 30 who received chemotherapy. They're not shown on this slide, and the factors that went into the decision to give those patients chemotherapy are somewhat uncertain. So this only applies to patients who, in their doctor's eyes, were appropriate candidates to receive hormonal therapy alone, but it is quite reassuring. We also have prospective data from the Plan B study. This looks at patients who have recurrence scores of between 0 and 11 and treated with endocrine therapy alone. And at 5 years, regardless of nodal status, they had an incredibly favorable outcome. There were 110 patients with positive lymph nodes who were in that group, shown in the dark blue line, which is actually superimposable with the chemoendocrine therapy group in the somewhat lighter line. But certainly for the patients with very low scores who had node-positive disease, those who received endocrine therapy alone in this prospective examination did extremely well. Whether or not chemotherapy added to those patients who had scores between 12 and 25, we simply don't know. And finally, these data come from a large study that Gabriel Hordavaji presented at San Antonio this year. So this was a analysis from both SEER or the combined SEER data in the US with Oncotype data. What was examined was the outcome for patients with both node negative as well as lymph node positive disease, again, 1 to 3 positive nodes. And what you can see is that for patients who had recurrence scores of 0 to 10 and had 1 to 3 positive lymph nodes, the breast cancer-specific survival was 98.2%, similar for scores of 11 to 15, a little bit lower for 16 to 20, and a little bit lower than that for 21 to 25. But I think what all of these data suggest is that the recurrence score is actually providing us with solid information in women who at least have a small burden of disease in the lymph nodes. Now, all of this is consistent with findings from the MINDAC trial. Remember that in MINDAC, patients with both node-negative disease and patients with 1 to 3 nodes were included, and patients who had high clinical risk but low genomic risk were randomized to receive either chemotherapy or not. There were a total of 801 patients who had 1 positive lymph node. Of those, 505 had a genomic low-risk score. They were considered clinically high risk because of the positive lymph node. And there were 226 who had 2 to 3 positive lymph nodes. All of these patients were randomized to chemotherapy plus endocrine therapy or endocrine therapy alone. And as you can see from both the overlapping curves and the table that is under those curves, that there appeared to be no benefit from chemotherapy in these patients who had 1 to 3 positive nodes, but had a genomically low-risk cancer based on the MammaPrint assay. Now, at our institution, we have adopted what we call reflex criteria for recurrence score testing. So rather than have every doctor order a test when he or she sees a patient, our surgeons actually go by this algorithm and order the test in advance of us seeing someone back for a discussion about adjuvant therapy. And we've tried to be relatively rigorous about the way we've done this. So we do not get a recurrence score automatically in any woman with a tumor that is 1 centimeter or less. We do not get one in anyone automatically above the age of 65. We do include patients who have both node-negative disease and 1 to 3 positive nodes. We include grade 2 and 3 in this group. We initially actually excluded patients with grade 3 disease, but discovered retrospectively that in fact, many of those patients with grade 3 disease who we had been assuming needed chemotherapy had low scores, low recurrence scores. And finally, if a patient has grade 1 disease, unless the tumor is greater than 2 centimeters or there is nodal involvement, we do not routinely get the test. Now, that said, any doctor is free to get a test on anyone else they want to. It's just that's not the norm for us. We do occasionally do it. There are occasional patients with 9-millimeter cancers who get tests. There are occasional patients with grade 1 tumors that are pushing 2 centimeters that get tested, but it does not happen with any frequency. And just finally, as we wrap up, what's my justification for the use in node-positive disease in the absence of prospective randomized data? And I have colleagues in the US who say, you just can't use this in node-positive disease because we do not have a prospective randomized trial that demonstrates that recurrence score can allow you to eliminate chemotherapy in node-positive patients. We do have a trial that has accrued and is now closed, the Responder trial, which included patients with 1 to 3 positive nodes and a recurrence score of 0 to 25. And I hope that sometime before my death, which is not likely, I hope to be very soon, that we will have a result. I'm told it's still going to be several years away. I'm planning to be around then. I think that once that is available, and assuming that study demonstrates that the recurrence score is able to predict the benefit of chemotherapy in these patients, I think it may potentially allow us to extrapolate to patients who have multi-node positive disease. But our exponder, in fact, is only addressing the 1 to 3 node population. But at this time, I actually think extrapolation from node negative to 1 to 3 positive nodes seems entirely reasonable. I'm not aware of any prognostic or predictive factor that works in node negative disease and doesn't work in node positive disease. I think the MINDAC data that I showed you provides supporting information. And I am actually quite persuaded by the registry data, though I recognize the weaknesses of the registry data, and I recognize that there are patients who had low recurrence scores who nonetheless received chemotherapy and were not included in those analyses. And so I'm not saying that no one should ever give chemotherapy to those patients who have low scores, but I certainly think you should think about it very, very carefully. So in conclusion, at present, the 21-gene recurrence score can help decision-making in patients with ER-positive stage 1 and I believe stage 2 breast cancer. It's not needed for all patients and certainly not needed if you've already decided to give or not to give chemotherapy. This isn't a test to just get because it's your whim. It's a test to get if you or your patient are undecided about chemotherapy. Increasingly, the question is not who who needs chemotherapy in addition to hormonal therapy. In the past, as recently as 5 to 10 years ago, the question was who doesn't need chemotherapy, and now I would argue that it's the small group of patients who need chemotherapy who we have to identify. As we narrow down the group of patients who have a higher risk of recurrence and a higher score on the 21-gene assay, I think we're going to be able to identify a group of patients who get a substantially greater benefit from chemotherapy than what we were traditionally used to seeing in ER-positive disease in the past. And so with that, I want to thank you all and introduce the next speaker.